Why does my leg ulcer not heal? Has anybody not had that asked? Has anybody had that question asked of them? Yeah? Hands, wave, good morning, good afternoon, we're up. Yeah, good. Okay, so it's really, really common. It's a question that we're asked all the time. And do we know how to answer it? So, what are we going to do this afternoon? Well, we've got a couple of really small aims, I think. Review the understanding of leg ulceration, and I can promise you that's going to be really quick because we did a lot of that yesterday in the workshops. And I'm going to look at ways in which we can help our members and other people to understand why the ulcer isn't healing and how we can help them help the ulcer to heal. Oh, wrong way, sorry. So, a leg ulcer. Well, we all know what a leg ulcer is. This is one of the slightly older quotes that it's a wound that doesn't heal after 6 weeks. And of course, yesterday we were discussing whether it's an injury to the lower leg which doesn't heal after 2 weeks if there is known arterial incompetence or venous incompetence. 6 weeks is not very long, is it? It's really not very long when you think about it in real terms. And some people may have already had their ulcer for a lot longer than that before they walk into the leg club or put themselves in front of any sort of healthcare professional. And the thing that they often say is, normally I'm such a good healer. I don't know what's gone wrong this time. And the cause of this is obviously the dog bite, the car door, the shopping trolley, everything and anything, but not normally what we know it is. But what is it? Do we see what they see, and do they see what we see? What do we see? What's on the picture? Anybody going to give me what they're seeing? There's lots and lots of different things in there, isn't there? And we all see what we see first of all, and the more we look at it, the more we see. And I think that's one of the things with leg ulceration. We see one thing, we may see it very, very clearly. It may be the vase that we're seeing really clearly because that's standing right out at us. That's a leg ulcer. I know the treatment for that. Let's do it. But the fact is that the person that the ulcer is attached to is maybe looking at the strumming Mexican there, and he's a little bit more laid back and taking it a little bit more easily. Leg ulcers are pretty awful things, really. And this is taken from a piece of research which is over 20 years old. And I make no apologies for using something so old, because patients do still feel pretty awful with a leg ulcer. Many of them cry, many of them are in pain. Gets in the way with things that they want to do, and depression. These are things that we see all the time. 20 years ago this was reported. And I like to think one of the best things about the leg clubs is actually it helps to address some of these. Just because many of our members may be older doesn't mean that they're not worried about how they look. Body image is very, very important to all of us. We heard about the body image of the veterans yesterday and how their body image completely changes. How do they feel about it? Is it the same as a leg ulcer? Well, it is if you're the person with a leg ulcer to a degree. Age, as I said, doesn't affect. Psychological aspects, social aspects, neurological aspects. Leg ulcers get in the way. Self-esteem, self-image and self-concept. These aren't new things, and they're not the domain of the young, fit, beautiful, lovely people. They're all of us. We all have this. All our members have this. And if they've had to be putting up with horrible, mucky legs, perhaps something like that, they are not going to feel good about themselves, and we really, really have to work to do something. It's a good picture, isn't it? Anybody else can smell it? Yeah, they have that really good, exudatey smell, don't they? That was after it came out the plastic bag, mind. You know the ladies that come in, they shuffle, don't they, and they squelch. But there we are. Would any of us like that? And then when you think, that's not common, but it's not uncommon. We've all seen something similar at some stage. And if you haven't, I think you're really, really lucky. Because I do find things like that. I find things that maybe they've not been able to cope with what was put on it, so they've taken it off, and it's a bit Heath Robinson when they put it back on themselves, because they'll reuse the bandage. They might even turn the dressing around, and then you're peeling off bits of kitchen roll and toilet paper and tissues. So it's not good. And people see this, and they don't want it for themselves, and then they're worrying that my leg isn't healing, it's going to be wet, it's going to be smelly, I can't do it. And we're all there going, if only you stuck to what you were expected to do, if you were concordant, compliant, if you were good. But would we be good? I'm never going to be concordant. I might adhere to a treatment plan if I know what that treatment plan is, but if I don't know, I'm not going to do it. And do we as practitioners know exactly what we want to do and how we're going to do it? Do we really know the history of what's in front of us? As I said, most patients will tell you they're normally good healers and it was the car door that did it. And that's your history. Well, if we take it from there, we're not going to get very far. Heidi, which is the circle, history, examination, investigation, diagnosis and indicators. That's one of Prof. Keith Harding's suggestions of how we go about things, and it's absolutely fine. We do need to know the history, but not just the history of the current wound. We need to know that individual person's social history, their current history. How are they generally? Who do they live with? How do they get around? How do they cook? How do they eat? All the things that we sort of take for granted, because we are never ever going to get an effective treatment plan which we are putting forward as best practice, they are signed up to and understand. We are never going to get that unless we actually get the facts right and keep that person central to all of it. They must lead it. If we lead, they may not follow. And often they don't. Think about yourself. Would you follow what you're told to do if you didn't really want to do it? Possibly not. We need to undertake the leg assessment, the ulcer assessment, because it may well have been the car door, but that just gave the initial injury. We have to find out why, and we have to understand what is going on underneath. We need to know the pathology of what's happening. How often are we assessing our legs, really? How often are we really looking at the wound, looking at the peri-wound, and the person? I know one of the things I like to do when I'm working in the leg clubs or seeing patients is, everyone will tell you I always take the longest at a station because I'm far too chatty. How are you? How are you doing? How are the kids? How are the grandkids? What have you been up to? Where have you been? How's this, that? Everything else before I get to the leg. By which time most of the poor girls in the leg clubs have already got most of the dressing down and the leg is in the bucket, and I'm still giving it all this. Because I want to get connected to that person. I want to be with them. I want them to come on this journey with me. Because if I'm going on a journey of a care plan and I haven't got them with me, what's going to happen? The leg ulcer is not going to heal. Because the person who the leg ulcer is attached to isn't engaged. They're not with us. They're still sat there thinking, I normally heal really, really well. That car door must have really, really banged my leg. Whenever we're doing assessments of the wound and everything else, it has to be accurate. We have to know exactly what we're doing. We have to be able to describe it. We've got to be able to pass it on to people. We can't guess. So we really need to take this seriously. We know that there's two main different types of ulcers. There's lots and lots. I know there's lots of others apart from arterial and venous, but these tend to be the main that we're looking at and the main two ulcers that we focus on. We know that arterial ulcers are as a result of a reduced blood supply, and very basically we know that a venous ulcer is a result of venous insufficiency. Within the arterial leg ulcers, plaques are laid down in the artery walls and we get further and further narrowing, and those ulcers tend to be, as we know, quite small but very deep. They drop very quickly, they break down very quickly, and we get a lot of pain. Signs and symptoms of what they look like there, we've all seen those, but that's slightly more interesting. This lady, her name was Jean. She has died now. She was a good 50 a day, and usually 10 of those were as you were getting out the car before you got into the house. This was pre one of our leg clubs. Classic arterial ulcers there. If you could see the rest of her, you would just see a cloud of smoke, because that's however we always saw her. But good pictures of arterial ulcers. Clinical signs of venous ulceration. Well, I think we did quite a bit of this yesterday in some of the workshops. We know one of the main things with venous ulcers compared to the arterial is they tend to be bigger, they tend to be slightly more shallower, tend to be wetter, usually nice, good and smelly as well. Now, I am so disappointed with this slide because yesterday in the compression workshops, didn't they have fantastic slides where they actually were moving? They had the animations which showed what went wrong with the veins. Did everybody else pick up on that? I want those slides. If they still, I want those slides. I want that animation because it suddenly shows you really what's going on and how compression works. And part of me thinks if we had those nice simple slides, and maybe we could show those within the leg clubs to explain to people, we can talk about how compression affects the valves in our veins, but if we actually can show them, even if it's an animation, it's really helping with the understanding. We've done that. We don't need to look any more at that. I want to get on to the really interesting part. Oh, that is a venous ulcer. Nice simple ulcer. I think, let's do this. Communication. Well, good communication starts by saying something clearly that it's understood. So when we're explaining to our new members or our members that have asked us, why is this not healing? We're doing a really good job, aren't we? We're telling them exactly why. We're reinforcing the message. But are we really doing this? Because great communication starts with saying something so clearly that it can't be misunderstood. And that's a huge difference between understanding or misunderstanding. There's a piece of research that was done by Heinen et al. In 2007, and it was looking at the adherence to compression and keeping it on. And they found that out of this population that they were studying, adherence to keeping it on was less than 35%. And these are people that are already in compression. So they've allowed the compression to go on, but they're not keeping it on. So why aren't they keeping it on? Are they not understanding? Have they not got the message? How about these happy chappies? Remember your males. Well, what are your males? Well, The first one is the message. What's the message that we're trying to communicate to people? We're trying to explain to them what the ulcer is, why it's there, and how we can help treat it. The audience is the person that's in front of you, the one person that you are talking to. Or maybe you're doing this collectively within your leg club. That's your audience. Remember them. Know what they know. Take on board the language that they use, how they speak. Speak with them, not at them. The language, we've just said that. Give examples. Now that's the other area where the leg club really excels, because we've got examples in everybody that's there. The other members can explain, they can show to each other what they're doing. They can help explain, understand the different types of compression. Members are great. You know, they will sit down and go, oh, yes, I had that and it really hurt at first, didn't it? But you know, if you keep it on, it will work. Or maybe they'll go, oh, I had that and it was blooming horrible. I took it off. I'm on something else now. But that's reality, but we've got to work with them. They will get through it. Another piece of research in 2010, which was done by Finlayson, they were interviewing people with venous leg ulceration. So these are people who've been diagnosed, they're being treated. Unfortunately, 42% of them didn't believe that their venous leg ulcer was caused by veins. They didn't say that wasn't the problem with their venous leg ulcer. The cause of their venous leg ulcer was in fact the car door or whatever it was that caused the initial injury. So it really is difficult, isn't it? And why? Why are people why are they not getting it? It's obvious to us as healthcare professionals, it's obvious. If you've got a venous leg ulcer, you treat it with compression. And many, many moons ago, a lady that you all probably know, Ellie Lindsay was her name, she came and gave a presentation. And one of the things that she said was, well, you know, the only way to heal a leg ulcer is with compression, isn't it? And we all went, well, yeah. And she goes, no, it's with what compression the patient will wear. And that's absolutely right, because we may want to do a full compression, we may want to put them in hosiery, we may want to put them in wraps, but if it's not acceptable to that person, it's never going to work. The leg ulcer is never going to heal. So where do people get these funny ideas from? Because some patients really have funny ideas, don't they, about healing and why it's not healing and what's going to happen. Well, we go on to another favourite of mine, which is the health belief model. And individual health beliefs will impact on how they accept the message that you're giving them, or even if they're actually going to believe it. So the health belief model explains why individual people may accept or reject preventative health measures or adopt healthy behaviours. So the healthy behaviour in this case may well be wearing the compression. They don't wear it, they take it off. Why? Because we're telling them if you keep it on, it will heal. But they know better, because they know their mother or their grandmother had leg ulcers. The Queen Mum had leg ulcers. They never healed for her, so it can't possibly work. They've got these ideas and we have to go with them. We've got to find the point with them and them at that single time that we can work with to move forward. And as it's got there, perceived susceptibility, will I get it? Well, yes, I've got it. I've got this leg ulcer, okay? How bad's it going to be? Well, it's not too bad at the moment. It's only little, and you know, I can change the dressing, and I don't need all that bandaging because it's hard work. Do they see wearing the bandages or the hosiery or the compression as a benefit? Well, yeah, maybe. You know, I could sort of see that. But I'm not going to wear it because I know it's not going to work. I mean, it's not going to work, is it? Because if it's not being worn, it's not going to work. Here's something that's really good. The better the relationship between the individual practitioner and the member, the better you're going to get adherence to treatment. The member must believe the treatment's going to work. They've got to believe it's going to work, because if they don't believe it, they're not going to do it. You know, how many of us here now are wearing our compression hosiery? Well done, Ellie. And someone else in the front. This is really unusual for me. I actually am not wearing compression hosiery. I tend to. But here we are, a informed, intelligent group of people who are talking about prevention and adherence to treatment plans, and we're not doing it ourselves. Now, are you all going to wear your compression bandages when you get leg ulcers? Or are you all going to know better that it's not going to happen to us? This, guys, is health belief. We all know we should wear them. We tell older people with lots of other comorbidities, you should wear them. But we don't. Do you know, we're storing up a massive problem for ourselves, really, aren't we? Are our leg ulcers going to heal? I think that's awful, isn't it? We have to give realistic outcomes, realistic expectations. If you are unable to wear your compression hosiery, your healing is going to take a very long time. You may never get ulcer closure. You may get management, but you may never get closure. The non-healing leg ulcer is as complex as the member it's attached to. I don't think any of us as individuals are simple people. I think we've got lots and lots of different aspects to each one of us, let alone everything else that's there. So, in conclusion, the member who is not adhering to the treatment plan, or should I say to our treatment plan, may just well be trying to get on with their life, trying to cope. They are not deliberately going against what you're advising. Maybe, just maybe, we need to review that plan that we've got and make sure it's the same plan as the member has got. Because if that plan relates directly to that member and they're on board with it, then you may well just get healing. Thank you.